Hello, I am Harry Erba, Professor of Medicine and Director of the Leukemia Program in the Division of Hematologic Malignancies and Cellular Therapy at Duke University in Durham, North Carolina. In this presentation, we will review cytogenetic and mutational analysis for AML risk stratification. As you know, there are a number of traditional and newer prognostic factors in acute myeloid leukemia. Patient age, performance status, and comorbid conditions are all important features that indicate a patient's ability to tolerate intensive chemotherapy with often curative intent. However, there are a number of features of the leukemia biology itself that are important in prognostication. We will focus in this presentation on cytogenetic analysis and molecular abnormalities. An evolving field is the use of techniques to measure minimal residual disease at the time of initial blast clearance after cytotoxic chemotherapy. We have known for decades that the AML leukemic blast karyotype is important in the determination of patient outcome in acute myeloid leukemia. For example, this data from the CLGB study evaluating high-dose cytarabine post-remission treatment shows a superior relapse-free survival for those patients with AML and a core binding factor translocation, the A21 translocation in inversion 16. However, half of the patients had normal karyotype AML, and all other patients were grouped together as other karyotype, having a worse outcome. With larger data sets, we have been able to glean the prognostic significance of other cytogenetic abnormalities. For example, in this United Kingdom Medical Research Council analysis of over 5,000 patients with acute myeloid leukemia, we again see that the overall survival of patients with core binding factor leukemias is superior to most other cytogenetic changes, with the exception of the 15-17 translocation of acute promyelocytic leukemia. We also see that a large group of patients with monosomy 5 or deletion 5q, monosomy 7 or deletion 7q, or AML with other MDS-related cytogenetic changes have a dismal overall survival of 10% or less. More recently, a nuance of the complex karyotype are those patients with autosomal monosomies. The monosomal karyotype is also associated with a very poor outcome regardless of the complexity of the karyotypic analysis. In the last 10 to 20 years, we have focused our attention on mutations occurring in specific genes. FLT3 is a receptor tyrosine kinase. It is found on bone marrow hematopoietic stem cells, but not differentiated cells, and it's activated by allosteric dimerization upon binding of the FLT3 ligand. It has a key role in hematopoiesis, but is highly expressed on AML blasts. There are several types of FLT3 mutation that have been described. The two most common are the internal tandem duplication occurring in 20 to 30% of AML patients, and tyrosine kinase domain point mutations occurring in 5 to 10% of patients. The internal tandem duplication in the juxtamembrane region of the protein relieves an autoinhibitory function, leading to activation of the tyrosine kinase. The missense mutations in the tyrosine kinase domain, the most common being at the aspartate residue at codon 385, activates the FLT3 kinase. The prognostic significance of FLT3 internal tandem duplication has been evaluated in a number of studies. In this analysis from the United Kingdom, 25% of their non-APL AML patients had a FLT3 internal tandem duplication. The presence or absence of the ITD did not affect the chance of achieving complete remission. However, patients with a FLT3 ITD had a higher rate of relapse, leading to a lower overall survival. We have also learned that the prognosis for patients with a FLT3 ITD-positive AML remains poor following allogeneic hematopoietic stem cell transplant, again due to the higher risk of relapse. The second gene to focus on is nucleophosmin. Nucleophosmin is a housekeeping protein, has multiple functions including regulation of ribosome biosynthesis, centrosome duplication, and modulation of p53 activity. In patients with acute myeloid leukemia, a 4-nucleotide insertion altering the translational reading frame can be found in the C terminus of the nucleophosmin protein, encoded by exon 12. This creates a nuclear export signal and delocalizes the nucleophosmin protein from its typical location in nucleoli in the nuclear envelope, seen in the top photomicrograph, to the cytoplasm. Nucleophosmin cytoplasmic mutations are found in approximately 50% of AML patients with a normal karyotype and are often associated with FLT3 mutations. Nucleophosmin mutated disease without the FLT3 internal tandem duplication has been considered a favorable genotype. The third gene to focus on is the CAAT enhancer binding protein alpha. CEBP alpha is a gene encoding a protein member of the family of basic region leucine zipper transcription factors, which are required for normal granulocytic maturation. CEBP alpha mutations are found in 5 to 10% of AML patients. There are two types of CEBP alpha mutations. The N-terminal out-of-frame insertions and deletions lead to the production of a truncated P30 protein from an internal start codon. The C-terminal mutations are typically in-frame insertions and deletions that will inactivate the normal CEBP alpha. CEBPA mutations are often associated with a normal karyotype. Biallelic CEBPA mutations are associated with a favorable prognosis. For example, this data from the German AML study group shows that patients with a nucleophosmin mutation without an ITD and those with CEBP alpha mutations have a superior relapse-free and overall survival compared to all other genotypes. One of the difficulties we have in interpreting data is sometimes the published literature disagrees on a topic. For example, in studies done also in Germany, the nucleophosmin cytoplasmic mutation, even without a FLT3-ITD, has been associated with a lower relapse-free survival in patients who did not have a donor compared to patients who did. However, the overall survival is similar between patients with a donor and without a donor, likely due to the ability for patients with relapsed AML with a nucleophosmin mutation without an ITD mutation achieving a second remission and then undergoing stem cell transplantation. Larger data sets were also important in determining that it's the patients with biallelic CEBP alpha mutations who seem to have a superior survival compared to those with either wild-type CEBP alpha or only a single mutation, as shown in this data from the United Kingdom. Furthermore, the larger data set allowed them to look at the interaction of the CEBP alpha mutation on overall survival, the interaction with the FLT3-ITD on overall survival. As you can see, the biallelic CEBP alpha mutation was found to have a beneficial prognostic impact only in those patients who did not have a FLT3-ITD mutation. This single gene analysis has been used to help improve the prognostication in acute myeloid leukemia with the normal karyotype. For example, in this model, factors such as age, performance status, white count at presentation, as well as nucleophosmin, FLT3, and CEBP alpha mutational status have been incorporated into a model for these patients with normal karyotype AML, which can then distinguish patients with a superior versus inferior overall and relapse-free survival.